Hello and happy Teach Me Tuesday. My name is Lisa Houston, and I am a NICU nurse educator here to bring you little bits of knowledge to help grow your practice and make you a more confident bedside NICU nurse. Whether you are a novice or someone that's been around for 20 years, I think there's something for everyone here. Today, during February, we are entering our third week of Heart Month, and this week we are going to revisit a topic we've dove into before about the transition of blood flow from intra to extrauterine circulation. However, there is no such thing as talking about this too much because it is a core concept. Even if you're a mom baby nurse, a level 2 nurse, a level 4 nurse, understanding what happens when that cord is clamped is essential for everyone that practices with babies. So let's review. During fetal development, circulation functions primarily on the placenta. If you know anything about me, you know that I'm obsessed with the placenta. I love talking about the placenta. The placenta is the greatest temporary organ to ever exist, and I will stand by that even though there are no other temporary organs until I'm blue in the face. But the placenta is where oxygenation happens, the cells gain their oxygen, and they drop off their waste, primarily CO2 and other waste that the baby doesn't need. So 3 primary shunts, the foraminal valley, the ductus arteriosus, and the ductus venosus, direct this blood flow away from the lungs and the liver because the lungs and the liver aren't needed during fetal circulation because of the placenta. At birth, these ducts start to close. They all close in their own order. And we have these other triggers happening, including breathing, including changes in our systemic vascular resistance or pulmonary vascular resistance, and oxygenation starts to happen. However, things can go wrong. So we're going to dive into all of this today. Let's review those shunts in detail because understanding the shunts and understanding the placenta, which we're going to go over next, is key to kind of understanding this whole entire process. So the foraminal valley is a glorified ASD. It's an atrial septal defect. It's a hole between the two atria, except for it's supposed to be there, so that's why it's not a defect. It is a little hole between the two atria that allows right to left shunting, right? Because we don't need the blood that's on the right side to go to the left, to the lungs and get oxygenated because it's already oxygenated. The ductus arteriosus is the PDA that we know it as, but the ductus arteriosus connects the pulmonary artery to the descending aorta, again, taking blood away from the lungs because it isn't really needed there. And then the ductus venosus is down below that, IVC, in that IVC area, and that's what allows the blood to bypass the liver because, again, we have the placenta that is doing the job of the liver to process all of the waste, so we don't need the liver. So these 3 structures are vital. If you look here in this picture, you're going to see that the ductus venosus is coming in right here kind of above the liver. Can you see this black little area? I need to relocate my pen that I lost. You see your ductus arteriosus, again, connecting that pulmonary artery and the descending aorta, and you see your foraminal valley, which is the shunt between the 2 atriums. All of that to be said, when we talked about how the normal heart functions last week in a setting of normal, primarily the right side is full of unoxygenated blood so that it goes up into the pulmonary artery to the lungs to get oxygen, and then the left side is oxygen rich and it goes up into the aorta to go out to the body. If you already have oxygen rich blood because the placenta has already oxygenated, it doesn't really need to go through that right-sided circulation. Yes, some blood is still going to go in. We have to get nutrients and oxygen to the heart, to the lungs. They also need to grow. But the primary blood flow is going to shunt from the right side to the left side so that it just can go out into the baby. And so fetal circulation is a giant right to left shunt. It's allowing all of this blood that's coming in on the right side via the pulmonary vein that drops into the IVC and then goes up into the right side of the heart to go to the left side. That's the point of that duct, which I also want to remind you, if you know anything about the ductus venosus, is also kind of this little trap door that allows your umbilical venous catheter to go in, right? And when it says it takes the turn, it's going into the liver instead of going up into the IVC. A little connection there. So that brings us to our old friend, the placenta. In the placenta, right? The placenta is like doing all this great stuff. It's exchanging gases, it's giving the blood the nutrients to go to the baby to help the baby grow, it's removing waste. It's doing the job of many organs in the baby's system that the baby will rely on when they come out. It allows that because there's low systemic vascular resistance, so that means that there's enough blood flow that can go there, and there's high pulmonary vascular resistance. So your systemic vascular resistance is your SVR, and your pulmonary vascular resistance is your PVR. So your systemic vascular resistance is nice and low. It allows this blood flow to happen, whereas your PVR, pulmonary vascular resistance, is high, meaning we don't really need blood to go into the lungs, again, because we have the placenta to do its job. When someone asks you in a trivia way, right, do lungs expand and contract in utero? The answer is yes, right? It's kind of a tricky answer because the lungs do, the baby does take these practice breaths. We allow the muscles to start to develop. You will see babies doing some breaths in utero, but they're not breathing in air and exchanging carbon dioxide and oxygen, right? Because the lungs are full of fluid. And that, again, is contributing to that high PVR. So you've already got these 3 ducts that are shunting the blood away, right, from the right side over to the left side of the circulation because they're already oxygenated. It brings all that back to the placenta. The placenta is doing its job to remove waste, to give nutrients, to give oxygen, and it can do that because of low SVR and high PVR. It's going to be key to understand those concepts as we go along here. So what happens when the cord's clamped? When the cord's clamped, whether you're doing delayed cord clamping for any period of time, whether that's 30 seconds, 2 minutes, maybe you have a birthing parent who wants to do until the cord stops pulsating, whatever happens, at some point we're going to lose the placental circulation, which means we can no longer allow the placenta to do this. We have to have the lungs and the heart ready to go. So what's going to happen is your systemic vascular resistance is going to increase. So the blood flow is going to be redirected to systemic circulation, right? So the left ventricle is going to start getting its major afterload. It's going to start doing its major job we talked about last week of really pumping that blood up the aorta and out into the body. Your blood flow, you're going to have increased blood flow to the right ventricle. So maybe the right ventricle didn't have to do a bunch of work before. Now it's going to have to because it's going to have to send the blood up the pulmonary artery to get to the lungs. So without that low resistance placental circulation, all of a sudden the blood is going to be able to go into the right places to reduce that right to left shunting. And then, of course, we need our pulmonary vascular resistance, our PVR, to drop significantly as the lungs expand during those first breaths, right? So the baby starts breathing, the lungs are expanding, and our pulmonary vascular resistance is going to drop. This allows for increased oxygenation and pulmonary blood flow. And it goes perfectly every time, end of slideshow, right? If only. Right? You have some things happen sometimes. So again, we're going to clamp the cord, which increases our systemic vascular resistance, redirecting flow of the blood into systemic circulation. Our first breath expands the lung, reducing our pulmonary vascular resistance, right? So now the pulmonary system, our lungs, are going to have increased blood flow so that they can start doing their exchanging of gases. Oxygen exposure now tells our 3 ducts, hey, it's time to start thinking about closing. Our foramen ovale usually closes pretty quickly. It functionally closes due to the increased left atrial pressure. That left is going to kind of be like, hey, door, it's time for you to close up. That trap door needs to shut. The ductus arteriosus is going to start constricting in response to high oxygen levels. Just remember, we all know that our duct can stick around for a period of time, especially on a small premature baby. Even on a term baby, we really say 24 to 48 hours is normal for the ductus arteriosus to remain open. And then also our ductus venosus is going to close as placental circulation ceases. There's just nothing going through there. Knowing those 3 ducts, this is, last week we talked about a trivia question, right? What's the number 1 congenital heart defect? So if I asked you, in a Jeopardy style, these are the 3 ducts that must remain open during in utero circulation and must close during, the transition to systemic circulation. The answers would be foramen ovale, ductus arteriosus, ductus venosus. So effective transition requires successful lung expansion and hemodynamic stability. So just thinking about those 2 things, how often is that happening, right? 10% of infants require resuscitation at birth, so we already are in a situation where maybe that's not happening, and 1% require extensive resuscitation, so you can imagine how it's continuing to not happen. Here it is in a photo, right? I think photos are so powerful. I think maybe that's why you are maybe even coming here if you're a visual learner or an auditory learner, so you can hear me talking through this. But in the fetal heart, right, you have this little foramen ovale, and we're just sending blood over. Our right ventricle isn't doing as much as it was. We have this very purple blood because it's already oxygenated. And yes, it is going to receive some deoxygenated blood as well, and that's why it's this shade of purple and it's not blue. If you remember last week, we really talked about what color is the aorta. Come back to that. So we have this little foramen ovale in our ductus arteriosus, which is wide open, so that we can allow any of this blood that's going to try to be going through the right side to shunt over to the left. So fetal circulation is a right to left shunt. So when all those things magically close and everything's sealed up in the right direction, we can now see this blue deoxygenated blood coming into the right side of the heart, going out into the lungs, getting oxygenated, coming back via the pulmonary veins, and then going out the aorta, where you see it's nice and red, and we've got our red aorta. So in this visual, if you want to pause and really look at kind of the difference in what that blood flow is doing in utero in a fetal heart and what it's doing in a newborn heart. So what happens when things go wrong? First, we have our PPHN, persistent pulmonary hypertension, which is essentially persistent fetal circulation. And the reason I've kind of like focused on saying all these things over and over again is because that was the aha moment for me with PPHN. When I finally understood PPHN is when I said to myself, the baby is trying to mimic fetal circulation. We haven't made the transition to this newborn circulation that we need. So we still have this right to left shunting, and we cannot get the oxygen in the ways that we need it to in the right parts of the body at the right place with the right percentage, and so the baby becomes hypoxemic. And the baby can become sicker and sicker, which we all know, right? Clinical signs, cyanosis, respiratory distress, differential saturations in your pre and post. We're going to need oxygen therapy. We might need mechanical ventilation. I see a lot of oscillators in this situation. INO. Our first week we talked about cardiac meds, sildenafil, Esmolol, all these medications that we talked about that could help with persistent pulmonary hypertension. And then obviously ECMO in severe cases. And when you think about it, you think about PPHN as being a constriction, right? Hypertension, I always think about like kind of like a cholesterol-filled artery. It's just like the visual I have. And that's similar in PPHN. Typically, we have kind of a wide open artery that it has this area for the blood to go, and it takes oxygenated blood out. But instead, it's more constricted because our systemic pressures, right? The pulmonary vascular resistance is still high. And because of that, the blood cannot circulate in the way it is meant to be. So PPHN is essentially, prolonged or persistent fetal circulation. And when you think about those two things, I do think it helps. We also can see transition go wrong with meconium aspiration syndrome because the lungs can't do what they're supposed to do. They're kind of filled with this fluid that is sticky and gnarly. If you ever change a meconium diaper, you know what this fluid is like. And in the setting of this thick fluid, the lungs are full of them. It causes airway obstruction. The lungs become inflamed. The alveoli are full of something they shouldn't be full of. Maybe they were full of fluid before, and the body's job is to get rid of that fluid. The capillary bed of the alveoli to get that fluid out cannot get the meconium through. So again, it's going to be kind of this constricture, and then that also will lead to persistent pulmonary hypertension, pulmonary resistance. These babies also need respiratory support. I've seen surfactant given many times. I've seen INO used. I've also seen a lot of kind of paralyzers in these situations to allow the lungs to just kind of do their job. And then, of course, we have our congenital heart defects that can contribute to this as well. These are just 3 examples that we've also talked about last week during our cyanotic and acyanotic congenital anomalies. But transposition, obviously, the blood is not going in the right situation as it is. They really require their PDA in utero. This is why some of these are so difficult to see in utero, because they have this fetal circulation that's typically just using that ductus arteriosus, and it looks like the blood's all going in the right way. Of course, in severe cases, we're going to see them coming off there. Hypoplastic left heart, again, we need that PDA to remain open. We don't want it to close. We're giving them some PDA or some PGE for that. And then coarctation, obviously if there's a major constriction, especially if that constriction, depending on where it is in relation to the PDA, is also going to be very impacted by what happens during this transition from intra to extrauterine circulation. Excessive oxygen administration can also lead to that duct closing. Sometimes we want to keep that duct open during PPHN because that might be the only way. Our ductus arteriosus is our only pathway for oxygenated blood to be getting to the baby. So you can see PGE be used with PPHN sometimes. Inadequate lung inflation may delay or prevent this change in your pulmonary vascular resistance, which would delay your normal transition. And obviously we're going to use some titrated oxygen, surfactant, pulmonary vasodilators, and maybe some of those paralyzers. So how can we help our parents with this? These are some good things maybe to talk about before a baby's born or if a baby's in any sort of distress. Obviously, if we have any of those confounding factors happening, such as a congenital anomaly, diaphragmatic hernias can lead to PPHN, obviously. So expected for a baby is to have a gradual improvement in their oxygen saturations, good respiratory effort, good muscle tone, stable cardiovascular parameters. If we start seeing persistent central cyanosis, severe respiratory distress, hypotonia, poor feeding, this is when we're starting to think, hey, maybe this transition didn't go well, or maybe the baby was reliant on one of those ducts and those ducts are closing. We want to really let our parents know that not all newborns transition smoothly, that they may need to go to the NICU, that this in the NICU could look like oxygen therapy, getting echocardiograms, having monitors on. It could lead to a transition to a different hospital. They might need to transfer. Maybe it's not just that we're taking you out of mom baby, but we have to take you to a whole new hospital because we don't have the capabilities for you here. Making sure that they're involved in these key decisions, making sure that the medical team is updating them frequently and allowing them as much bonding and touch hold as they can. So today on our Teach Me Tuesday, we've learned that this transition from intra to extrauterine circulation, blood flow of the blood, oxygen delivery, is pretty, I don't know, I guess I would say it's like almost there is it's dependent on very many steps. That's what I would say. Like in engineering, it's like you got to have one thing that comes before the next that goes to the next. And if something goes wrong in this cascading of events of an algorithm almost, you can see that the baby could be in distress. We need to have those three ducts, your foramen ovale, your ductus venosus, and your ductus arteriosus, open in utero because it's the placenta's job to exchange the gases and remove the waste. Blood from the placenta to the baby is going to bypass the liver and the lungs during fetal circulation. That's its intended purpose because of the placenta. You can also imagine if the placenta isn't functioning well, right? We're going to be talking about the placenta more in March. She'll come back. But if the placenta isn't functioning right, you can also see how this could contribute to more things. But any failure in the transition can lead to significant complications. Premature closure of the ducts, maybe a duct that the baby is dependent on, pulmonary hypertension, a switch in your pulmonary vascular resistance doesn't happen, a switch in your systemic vascular resistance doesn't happen. All of those are going to contribute. This baby might need help with oxygen, they may need targeted therapies, medications, or again, a transfer to another facility. So we need to make sure that we're updating our parents, helping them understand the normal transition process, what this abnormal transition is looking like, and empowering them to participate in their infant's care. Thank you for joining me today on this Teach Me Tuesday. I hope this, covering intra to extrauterine transition has helped. I think it's really important for us to understand so that we can recognize when things are going to go wrong. Please be sure to like and subscribe if you've watched this whole video and you like what you're seeing, and check back next Tuesday for another edition of Teach Me Tuesday with Lisa, the NICU educator.